Donnie is a 12-year-old male diagnosed with moderate intellectual delays, anxiety disorder, attention deficit hyperactivity disorder, oppositional disorder, and he's on the spectrum. Donnie currently resides in an inpatient setting. He's very healthy and his family is very dedicated and devoted. He was admitted to the inpatient setting for assessment and stabilization of his medication regimen. Donnie currently receives Lamictal 100 milligrams twice a day, clonidine 0.025 milligrams a day, and clonazepam 25 milligrams a day. Currently, his medication regimen remains stable and unchanged. As part of his inpatient stay, Donnie does receive educational services to meet his academic needs. He receives tutorial services 5 days a week, 4 hours a day. Miss Tina, Donnie's tutorial teacher, referred Donnie to me because of her concern over his increased level of non-compliant behavior, which seems to be affecting his academic progress in a negative way. I met with Miss Tina and we reviewed and determined that the target behavior that we would be addressing would be non-compliance. We also defined the behavior as putting his head down on his desk, lasting for 5 seconds or longer, wandering around the room when presented with a task or given a task that lasted 5 seconds or longer, talking to other individuals about other topics of conversation that lasted 5 seconds or longer that had nothing to do with the task at hand. Also, pushing the task away when presented it by Miss Tina and saying, "Go away, leave me alone, I don't want to do it." I met with Miss Tina for a training session. We reviewed the definition. We reviewed examples and non-examples of non-compliant behavior. I also reviewed with her the data sheet that I created. We decided to collect data on frequency counts, given that Ms. Tina was going to be the data collector and the one presenting Donnie with the tasks and instructing him to do the tasks. When I met with Ms. Tina to review the data collection and to obtain accurate data, we role played a few examples. So, as an example of non-compliant behavior during baseline, Ms. Tina would say, "Donnie, please do these 5 math problems." Ms. Tina would wait 5 seconds. Donnie didn't respond. He'd look around, he'd walk around. "Donnie, please, you have 5 math problems. Please do these 5 math problems." Donnie would put his head down on his desk. Ms. Tina would wait 5 seconds. "Donnie, please do these 5 math problems." Ms. Tina would wait 5 seconds. If at the third reminder, at the end of 5 seconds, if Donnie didn't respond, then that was counted as a non-compliance on the data sheet. So Ms. Tina would put a tally mark on the data sheet, and we would consider that a non-compliance. We decided as part of this investigation to do an A/B design. Ms. Tina was the primary data collector. I also had 2 staff people who interchangeably worked within the tutorial session to collect IOA data. The reason why I had these 2 staff people in particular is because Donnie was accustomed to seeing their presence. So observer reactivity really became a non-issue in this instance. We collected data at baseline. While the data was being collected during baseline, I reviewed Donnie's past history, sort of information that was obtained prior to his hospitalization. A BCBA had done a formal FBA. And based on the results of that FBA, it was determined that Donnie really responded to social reinforcement. So the maintaining reinforcement for a lot of his negative and maladaptive behaviors were in order to access some form of social reinforcement or some sort of tangible rewards. In reviewing the literature around non-compliant behavior and how to address non-compliant behavior, and based on the results of the FBA, I determined as part of the intervention plan to decrease his noncompliance was to use social reinforcement and tangible rewards. Donnie is particularly reinforced by not only attention from the adult, by also superheroes. A point sheet was developed and laminated with Velcro, and the points that we used with Donnie for engaging in compliant behavior was Hulk points. So pictures of the Hulk were printed out, and miniature versions of a picture, maybe a 2x2 picture, was cut and laminated, and so those were considered his points for his point sheet. So every time Donnie engaged in compliant behavior, meaning he responded with 2 or less prompts that were 5 seconds apart, he earned a Hulk point. A Hulk point was then placed on his point sheet. Donnie also was an active participant in terms of placing those Hulk points on the point sheet, and we did review the intervention plan with Donnie, meaning we talked to him about it, and we explained to him that we wanted to help him. We wanted to help him get better at getting his schoolwork done, so he would learn new things and do well academically. And Donnie was really receptive to the intervention plan. So given the restrictions of an inpatient setting, given the staff schedules and the staff who are obtaining the IOAs, given the variability in their schedules, and given that we were informed at a meeting that Donnie's discharge was impending, but there wasn't a definite discharge plan, but everyone was working on having him discharged from the inpatient setting. I felt it necessary to prioritize this investigation. So in terms of treatment fidelity, in terms of generalization, in terms of those aspects of this investigation, those were not planned for. I did not have time to really sort of think about treatment fidelity and generalization and how to sort of incorporate that into this investigation. So that would be a limitation that should be looked at further down the line. What the results of this investigation did show was that based on the IOA, that accurate data collection was obtained, that the IOA was obtained every third day for each phase, and the IOA ranged between 80 to 89%. So that was an acceptable range in terms of this investigation. If we look at a graph, if we were to look at a graph and the frequency counts, you would see, so these are frequency counts on Donnie's non-compliant behavior for each intervention. Also included in the graph is the IOA, so the inter-observer agreement for each intervention, and it's clearly stated on which day the IOA was obtained. If you were to look at the baseline phase, you're looking at a range of anywhere between 11 to 9 in terms of frequency count for his non-compliant behaviors. So 11, 9, 10, 9, 11 were the frequency counts for the initial baseline, and as you can see, it's pretty stable. There's some variability, but not significant. When we introduced the intervention plan in terms of the Hulk points, earning 5 Hulk points to access 5 minutes of an iPad, you can see that the intervention phase, that this form of social attention and positive tangible rewards were effective in decreasing Donnie's non-compliance. So you're looking at a range between 5 and 2. So 5, 4, 4, 3, 2 were the frequency counts for his level of noncompliance. When we withdrew the intervention and went back to baseline, you can see that the frequency counts went up again. So it started to increase. So his level of noncompliance increased. So you're looking at a range of 6, 8, 6, 10, 11 were the frequency counts during the second baseline phase. And then when we return to the intervention phase, you can see again that the intervention was effective and decreasing Donnie's level of noncompliance. So you're looking at a 5, 6, 5, 4, 4. So 4, 4 kind of leveled off here a little bit. And at around this time, I think 2 or 3 days later, he was discharged from the inpatient setting. I also provided a graph down here, which kind of, what I did is I took the mean averages for the frequency counts up here. So the mean averages on graph 2 for the frequency counts up here. And what I mean by that, so I added each frequency count, I added the frequency counts, and then I divided by the number of sessions, which was 5. So I got a mean average, and you can see the mean averages for the frequency counts really shows the same thing, that things are relatively stable across interventions, and that the intervention in itself was effective. In terms, again, going back to IOA, in terms of IOA, I did mean count per interval, and I felt that was sort of the most accurate way to establish IOA for this investigation, and it was pretty effective in terms of doing that and serving that purpose. Now, again, going back to the limitations again were that there were a lot of time constraints around the inpatient setting, that I needed to prioritize this investigation. So treatment fidelity was sort of put on the side. I basically used the training sessions with both the two staff collecting IOA and with Ms. Tina as sort of a way to establish accurate data collection and accurate treatment fidelity, and how to implement the interventions at baseline, and how to implement the interventions during the intervention phase, so that there weren't any confounding variables. I think future investigations, if I had more time and opportunity, I would do a treatment fidelity checklist to make sure that the interventions were implemented during the intervention phase accurately, and to make sure that the prompting procedures were implemented accurately during baseline, so that there wasn't any issues of confounds in terms of social reinforcement, in hopes that things were, there was a clear distinction between intervention and baseline. I also later on found out that one of the staff obtaining IOA was a highly preferred staff to Donnie, so that could have been another issue where it may have confounded the results, so that the presence of that staff during IOA, during both baseline and intervention phases, confounded the results a little bit. The results did show that the intervention was effective in terms of decreasing Donnie's level of noncompliance for the time period that we had him. Generalization we could not explore during this investigation. Again, it goes back to the constraints that I talked about earlier. So if I had more time and opportunity with Donnie, that's something I would also explore explore. And then going down the line, if I had more time and opportunity outside of an inpatient setting and a different treatment or clinical setting, I would love to do this type of investigation with kids who respond really well to this type of social and tangible reinforcement in terms of non-compliance issues, and sort of addressing it with different kids from different skill sets, different levels of functioning, different races. So that's something that would need to be explored further down the line. So this was the results of my investigation. I hope you enjoyed my presentation, and thank you very much.